Hello and welcome to another episode of Social Workers Arise. It is your host, Catherine here. If you don't know about me, my name is Catherine Moore. I'm the host of the Social Workers Rise podcast and have been doing this podcast since January of 2020. A lot of my work has been based in the medical field of social work. So I have my master's in social work, my bachelor's in social work, and I've been a licensed clinical social worker since 2019. Currently, during my day job, I do therapy, but I'm also a professional speaker, a trainer, course content creator, and also an author. So I do a little bit of everything and I love it. One of my absolute favorite parts about social work is working in the medical setting. So I've done hospice, doing home visits with hospice. I've been part of a palliative care team working in an outpatient office setting. I have done medical teletherapy, and I've also worked for a couple years in a hospital. So I feel like I have a pretty wide range of medical experience to speak on. And one of the hot topics that I always get asked about is hospital social work. This seems to be the creme de la creme of medical social work. Whenever I talk to new interns or new social workers in grad school, a lot of them seem to want to go work in the hospitals. It's a prestigious job and it's a lot of people's goals. However, it can be really, really hard to get in if you've never worked in a hospital before, because a lot of times hospitals want to see that you have previous medical experience, and it can be hard to get in if you don't have that. So where do you even begin? This is episode 192. We're going to be talking about hospital social work, around what is it that you can expect to be doing in the hospital, and what are some ways that you can get your foot in the door. If you can't get hired at a hospital, what other places might you get hired at? So I'll start off with the basics. So as a hospital social worker, you can be working in either all sorts of different areas, or you can be focused in on one area. It just depends on the role that you're hired for. A lot of times it may be easier to get in as a per diem or a part-time hospital social worker. And with that, you can expect to work in a lot of different areas, because sometimes they'll be calling you in to just fill in wherever there is a need, right? So the parts of the hospital that we had, and again, this is based in Southern California. This hospital is just one example. It doesn't mean that your hospital is the same. You may have other areas that I don't mention here, but this is just to give you a brief overview, right? So generally in the hospital, there's going to be the emergency room department. This is usually always hiring for people. It's fast paced. You have to have a lot of good skills to be able to think on your feet. So this is why they want you to have some prior experience before they just throw you into the emergency department, because you don't know who is rolling through that door or what has happened to them. And so it depends on the hospital that you're interviewing at, that you're working at. If it's a trauma hospital, that means that people could come into the emergency department with significant injury, like traumatic stuff, gunshots, stab wounds, car accidents, missing limbs, plane crashes. I don't know. What else? Terrorism, right? Terrorist attacks. So there's a lot of different things that you will see coming in through those doors, burn victims, car crashes. So a lot of that's what it means to be a trauma hospital. And that is also going to require a specific skill set. And a lot of times when you're going into these jobs, they're going to want to know when you're interviewing that you know what you're getting yourself into, that you can handle it, that you're not going to see a grieving family and freak out and not know what to do, right? So that's, again, why a lot of hospitals do ask to have a license, but some of them don't. Some of them will hire you straight out of graduate school, probably not maybe out of bachelor's, I guess it depends, but I've never heard of that. A lot of these positions, you at least need a master's degree. And The other good thing about medical social work, kind of backtracking a little bit, is that the average pay in 2024 is between 77 to 88,000 per year if you are working full time. And this is a statistic based on the entire United States. So if you, depending on where you live, that may be more or less, right? So going back to the hospitals, there's the emergency room department. If it's not a trauma hospital, then you can kind of expect a lot less intense people coming in, but still very high stress, very fast paced. So the hospital I worked at was not a trauma hospital. The types of folks that we would have come in would be people experiencing homelessness, people having psychotic breaks, people who are overdosing on drugs, people having heart attacks, shortness of breath. So a lot of these different types of things. The ones that we were called to as social workers would be homelessness for resources. It would be addiction. So if they are asking for maybe sober livings or some kind of substance abuse rehab, then we would provide resources for that. Also, psychiatric holds. So people who have attempted suicide, they would automatically go in for a psychiatric hold, and we would then work with the psychiatric hospital because we weren't a psychiatric hospital. So we would collaborate with the local one in our community and do the evaluations and that, what they call a 5150, and work with them that way. The other areas, so that's kind of just a snapshot of the emergency room department, right? The other areas also could be the intensive care unit or the ICU. And this is where people go who have very, very high needs. A lot of times they might be on a ventilator, they are close to death, they are really high risk of passing away. So a lot of times people might go from the emergency department over to the ICU, intensive care unit, and that's kind of where they can get stabilized and assessed really intensely, and there's a high level of care in the ICU. While in that department, which that department was personally my favorite because one, you kind of had more time because typically people don't discharge straight from ICU out. So you at least have a day or two to get to know the patient, contact the family, be able to gather some information, work with the doctors, the interdisciplinary team, work with the respiratory therapist, the chaplain. So it's a very large amount of collaboration that happens everywhere in the hospital. But specifically in the ICU, that's what that would look like. Is there's team meetings every single morning or whenever, right? Every day you have team meetings working with the IDT team. And this is where you, as a social worker, have to really know your stuff and be able to feel confident because some of those doctors aren't very nice, to be honest. Some of them are kind, but they're really just there to get the job done. And you need to be confident in your clinical skills, in your assessment, and know what you're doing when you show up to those meetings. And supervision can be really helpful. Collaboration with colleagues can be really helpful, especially around challenging situations. One of the most challenging story that I experienced working in the ICU, it was usually around the younger people. So people who have attempted suicide. That was always, for me personally, one of the most challenging ones because there's just so much going on, right? You have your patient's mental health. They may or may not be able to talk to you. And then you have a family coming in. They're very distraught, very worried. And it just felt really unnatural to have such a young person there in the ICU. And, talking about suicide and how do we support them and what are the next steps and if the person has children or a family. So a lot of different dynamics that are going on there. Another common situation that you could run into at the hospital is if somebody is no longer healing or doing well and they are anticipated to die. That's going to be a conversation that you as a social worker need to be prepared to have with the family, probably not with the patient, but in collaboration with the medical team to figure out, okay, they have a terminal diagnosis. What now? Do we start hospice? Are they even able to go home, or do you need to have end of life services here in the hospital? How do we make them most comfortable? Do you want life support? Do you not want life support? Do you need a chaplain, spiritual arrangements, mortuary arrangements? What are we going to do after they pass away? If they are going home, are they going to be safe? Do they have the caregivers that they need? So a lot of work around end of life care as well that can come up in the hospitals too. Another part of the hospital could going to be the birthing unit. So the place where babies are born and working there. So there's a lot that also goes into this part as well. So a lot of education and support around with the new parents. If they have questions around what to do, how to care for the baby, you'll work in collaboration with the nurses and the medical team there. What about drug use, marijuana use? Doing all these assessments. Is the baby going to be safe at home? What kind of social supports do they have? Where's the income coming from? Do they need financial resources? Do they need food? What is it that this family needs in order to be safe and to be as stable as possible with the baby? The other hard situations that I've experienced working in the birthing unit, two that come to mind is one, there was a mother who was using drugs. She was fresh out of jail and she was using drugs, and she had her baby and the baby tested positive. And so now this is a mandatory CPS or Child Protection Services report, and talking with the social worker, with CPS, talking with the mom. And it was just a very challenging situation because, I've never worked with CPS. So this was a new experience for me. And just really hard to be able to hear the mom's story. And I feel empathy for the mom, but I'm also like, okay, well, your baby is now addicted. And this is the system that we have, right? This is no longer me as the individual social worker deciding what to do. Now, since this has happened, this goes to a system level, and there needs to be reports that are made and really, really good documentation that's made, that I've done everything, that I've talked to the interdisciplinary team, that I've talked with the parents, and I'm making sure that I'm doing what I need to make sure that this baby is safe. So there's a lot that goes into that as well. The other really challenging situation, it was probably the worst day of my life as a social worker, but was the moment that we realized one of the mothers had fallen asleep with the baby in her arms, and the baby actually suffocated and died there in the hospital. And it was a really horrific experience that I'll be honest, I was like a deer in the headlights, like, oh my gosh, I wouldn't even fathom that this would happen, but this does happen. And, there's a lot of different areas that you need to be prepared for. So luckily I had training in grief, in crisis response, and you just never know in working in hospitals, or really anywhere, but especially hospitals, you just never know when a crisis is going to occur. And so you really have to be able to know your skill set, know what you bring, and know, okay, this is out of my skill set. Please let me consult with somebody. Let me see what the heck am I supposed to do here. So fortunately, in the situations that I didn't know exactly what to do, I did have colleagues that were very supportive, and I was able to reach out to them. But it's just, you never know what's going to happen in the hospital, which some people love that. Some people, it stresses them out. It's up to you to make that decision, right? Other areas of the hospital that you might work in. We're going to hit pause on this conversation real quick, because the next time that you need continuing education units, I highly recommend the Therapist Development Center. TDC has helped more than 100,000 social workers pass their licensing exams, including myself. I love that TDC CE courses are engaging and relevant. Amanda and her experts give us clear and practical skills that we can immediately apply to our work. Some of my favorites are their Edge of Life Suicide Prevention course, where Amanda shares her personal experiences, and their They Did What? law and ethics course that looks at real cases where therapists faced formal disciplinary actions. We are legally required to take continuing education to increase our competence, and most other courses out there don't actually teach the material in a way that we can learn it, but TDC does. Check out the links in the show notes. If you are looking for continuing education credits, make sure that you check out CHEP, CHEP. This organization provides high-quality CEUs, continuing education units, and as a bonus, all of the profits from their CE courses go directly to supporting homeless veterans. So not only are you getting your continuing education credits, you're also supporting out a great cause. Make sure to check out the link in the show notes to find out how you can get started with your continuing education credits today. So other areas in the hospital that you might work in could include the oncology unit, so people with cancer. That is also, I worked in palliative care for a long time, and that also included a lot of people with cancer because they're going through treatment, and eventually sometimes it gets to where the treatment is no longer helping and it can actually be harmful to the patient. So being able to be that liaison between the patient and the medical team, making sure that the patient and the family feel well supported, that they have the information that they need, that they understand what's happening, they understand what's going on. If they need a durable power of attorney, that's also something that is going to be a lot of times on the social worker to have that conversation around getting people to sign, like, maybe a do not resuscitate order, or making it to where they designate somebody to be their healthcare power of attorney. So a lot of different things that go into hospital social work. Another area could be surgery. So people going in for surgery, making sure that they're prepared, and then people coming out of surgery, making sure that when they go home, that they are safe, that they're able to provide for their needs. If they have a caregiver, that the caregiver understands what this entails, that they're prepared if they need resources, home delivered meals, things like that. That's another area that you could be working in. Another area is kind of the general medical units. So this could be pretty much anybody, right? So people who are not in the intensive care unit, but they're just in the hospital, getting monitoring. They are planning for discharge. So what does it look like when they go home? What are there going to be the needs? This is where a lot of the case management comes in. So if you're doing those types of tasks, that's going to be arranging transportation home. Do they have a wheelchair? Do they have a medical bed? What does that look like? What kind of resources do they need at home so that they stay at home and they don't get readmitted back to the hospital? That's a big one, is that hospitals don't want people readmitted. And there's a high likelihood of patients going home and then within 1 week, they get admitted back to the hospital. And that is what the social workers really, really try to prevent, and where we save hospitals a whole heck of a lot of money. Just making sure that patients are safe when they do go home, and that they're ready to go home and they have the tools and they feel confident going home. So that is an overview of hospitals, a lot of the main areas of the hospital. You notice that a lot of these areas are really high needs, high intensity, high complexity cases. A lot of times there's going to be a lot of psychosocial education. There's going to be a lot of interdisciplinary team meetings. There's going to be a knowledge of the ethics, right? So at what point in time are people able to make their own medical decision? At what point in time are they not able to make that, right? There's going to be points where you're going to come up with ethics where, okay, this adult is not safe at home because they're by themselves. They're not safe, but they want to go home. They don't want to go to a facility. They're refusing to go to any kind of nursing facility. So you're sending this person home knowing that they're unsafe, but at the same time, you're honoring their right to self-determination. So there's a lot of ethical conflicts there, a lot of ethical tensions that the medical team needs to be prepared to consult with, and that you need to know the ethics around that as well, as far as how it relies, or how social work ethics are involved in that. So if you're going into an interview, there are going to be some things that you may be asked about, and some topics to be prepared to speak on, and how you have experience in different topics or different areas, right? So some of the major areas that I kind of touched on is going to be crisis intervention, making reports. So adult protective services, child protective services, you need to know when those reports need to be made in your state. How to work with people who are in a psychiatric crisis. Maybe how to assess if people are suicidal. If people are coming in with end of life care, are you prepared to have these types of conversations with them? With discharge planning, how familiar are you with the community resources in your area to be able to refer out? How familiar are you with health insurance and being able to get people connected with the federal health insurance or with the local food stamps program, whatever it might be? The other thing that is inevitably going to come up is your cultural sensitivity. So how well do you work with diverse populations? Because hospitals, oh man, everybody's going to the hospital, and you need to be able to show that you're culturally competent in working with these different populations. So if you are trying to get into a hospital, here are some tips. One, make sure you know what skill set you bring, because you're really going to want to emphasize those skill sets. Have a list of them, be very confident in them, even if it's internships, even if it's personal experiences. All of these things can count towards building your credibility as the social worker for the hospital. Okay. The other area that I would also recommend is maybe considering another medical setting that's not a hospital. So I did a whole episode on the different types of medical social work, and that can be really helpful when job searching. It's going to be episode 183, types of medical social work. And so by starting in a different setting, like a skilled nursing facility, a dialysis center, a hospice center, this may give you the foot in the door that you need in order to get hired at the hospital, and give you the experience too to see, is this something that you even want to do? Do you actually know what you're going to get yourself into? Are you prepared to be in these different types of situations? So I hope this is helpful. Again, this is not a full overview of everything that you're going to do as a medical social worker in a hospital, but I hope it at least gives you a little peek inside to what it's like, to what kind of situations you're going to need to be well versed in. I did a reel a while ago, and I'll probably re-release it. But in one day, I wrote down all of the different topics and areas that I helped with in the hospital. And there was, oh my gosh, like at least 20 different topics that I touched on. So addiction, substance use, right? Child protection services, hospice, palliative, domestic violence, reporting requirements, ethical dilemmas with seniors. I forget the whole list, but there is a whole list, because it's like every single person that you go to see, they're going to be a different topic. And at the time I was working per diem, and so I'm around the whole hospital seeing all of the different types of patients that I just talked about, people with really high needs in the ER and people with lower needs who are getting discharged out, family members, children, nurses. So there's a whole slew of different areas that you're going to see in hospital social work. If this episode was helpful for you, if it reminded you of somebody that you think would appreciate it, please go ahead and share this out. You can post it on Instagram, tag me at Social Workers Rise, text it to a friend, say, hey, check this out. It reminded me of you, something that might be helpful for you, because we are not about gatekeeping of information around here. Lastly, if this is an area that you want to get stronger in, I have 2 courses that might be of interest to you depending on what you're looking for. One is the POLST Basics for Medical Social Workers. So POLST is essentially a DNR order What does this look like? How do you do it? How do you have these conversations? Even if you don't have a post, it might have a different name in your state. It is a lot of the same information. And how do we have these conversations effectively and in a compassionate way without ruining our rapport with the clients? The other one is around if you are looking for more support, specifically with documentation, your clinical interventions with termination, and then the clinical essentials for the social worker may be for you. I'm sorry, the clinical essentials for the future therapist. That course may be for you because it goes really in depth as far as how to do an effective assessment, which you will do assessments a lot as a medical social worker, how to do effective assessments, how to document effectively, which both of those areas are super duper important in hospital social work and should be added to your skills that you can expect them to ask about in the interview. So that is it, my friend. It was great talking with you, and I will see you next week. Bye.